Welcome everyone and good evening. This is the SAB's March educational webinar event, Mastering Malignant Airway Obstruction, a Decade of Insights from Advanced Bronchoscopy Techniques with Dr. Roy Cho. Tonight, before we get started, just a few housekeeping and reminders for our audience. If you're new to the SAB webinars, we encourage and influence you to ask your questions throughout, and you may use the drop-down feature within your control panel, or you can raise your hand and we will address all the questions after Dr. Cho's presentation. At this time, I'm going to hand it off to Dr. Hussam Naif, who sits on the SAB's Education and Program Committee, as well as the Chair of the Industry Relations, and he will begin tonight's presentation. Thank you all for joining.
Thank you, Emily. Welcome everyone to the Society of Advanced Bronchoscopy educational webinar. Your host today is Hussam Naif. We present to you on a monthly basis discussions and reviews in advanced bronchoscopy and interventional pulmonology. Today we have an exciting topic and a great speaker, Dr. Roy Cho, presenting to us today about central airway obstruction, and he is an associate professor at the University of Minnesota, Faculty of Medicine, and one of the IP faculty in the section of interventional pulmonology. Dr. Cho is a director of bronchoscopy at University of Minnesota Medical Center and a co-director of complex airway program. Without further ado, Doctor.
Thank you. Good evening, everyone. First, I'd like to thank the Society of Advanced Bronchoscopy for hosting this and inviting me to talk. Second, thanks to the audience for attending this event. I'd like to preface this talk by saying venues like this are really good for what we do, because it allows for us to leave our individual shops and get together and discuss important topics like this. Also share ideas and kind of gives us all some tips that help us along the way. I think we should have enough time at the end of the talk for any questions, comments. So I think we can get started from now. So conflict of interest. So these are just the relevant things that we'll find during the talk. I've been involved just in advisory boards, some educational and research events, and also device licensing with these companies. The presenter, all the slides are mine, all the images are mine, so there's really no other conflict of interest from that standpoint. Okay, so the objectives. We're going to give you a general overview of central airway obstruction, what it is, how it presents typically, and one of the key things is how you assess it from a patient standpoint. So from the pre-procedure side, what are the different interventions we can do for a patient with central airway obstructions? How do we take care of this patient right after the implant or after any intervention? And then some final thoughts and summary. So if you look to the right, there's a chest x-ray and there's a CT scan. So I'm going to begin the talk with just a very brief clinical presentation of a patient that's in her early 60s with COPD, who, as you can see, has a endotracheal tube for acute respiratory failure. You can see the left side of the chest. There's a whiteout or opacity. And if you look at the CT scan, the correlate scan shows a really sizable left upper lobe mass with obstruction of the left main. So when you see patients like this, and I'm sure you guys will come across patients like this, the main key of this talk is how you assess this kind of patient and then determine what the patient will need if there is an intervention. So central airway obstruction, we've probably seen these slides many times before, but it's very important to keep that in the back of your mind. There's generally three mechanisms, whether it's obstruction from a pure endotracheal or endobronchial tumor, a pure extrinsic compression where the airway mucosa is intact, but it's just an extrinsic compression caused narrowing of the airway, or mixed obstruction where there's infiltrative disease from something extrinsic, and then now you have mucosal involvement. So if you look at the photos on the right, these are different locations where you can get central airway obstruction. So you see a subglottic stenosis, and then to the right you see a tracheal narrowing, and that's from Malaysia. The bottom left is bilateral main stem obstruction. And then on the bottom right, and especially if you're a transplant facility, you'll see central airway obstruction post lung transplant just from an anastomotic issues. When you assess a patient like this, it's really important to get the cancer history, risk factors, and whether it could be operative risk factors or prognostic factors. It's important to get a previous CT or bronchoscopy, especially if it's another hospital sending you this patient and they've been assessed by a pulmonologist. And if they said they've performed a bronchoscopy already or have already have CTs, it's really important to obtain those images before you put in a lot of effort transporting the patient or transferring the patient to your facility for a potential intervention. Degrees of symptoms, so you can't fix asymptomatic, right? So the patients have to be symptomatic, at least that's what I tell my fellows, if we're gonna decide on any kind of intervention for that patient. Goals and expectations, so the main thing, especially for incoming fellows, is is this something that can be opened? So that's a very, very good question, and that's the things that we're going to be talking about throughout this talk. And then risk benefit, is it risky to bring this patient in there? Because we want patients to get on the table and get off the table. So all of these things we'll talk about throughout this presentation. So can we open it? These traditional no-go reasons when I was a fellow was heterogeneous enhancement sign and cavitation, meaning that now there's necrotic disease there. It's not healthy lung tissue, and most likely those kind of that phenomenon is not generally accessible, or if you do intervene, may not be able to be opened or functional. And then any atelectasis greater than 4 weeks have used to be kind of these traditional bullet points for inability to get patency. And throughout the years, I think that generally these are true, but there are cases where sometimes it's not true. And we'll talk about this, how you further assess patients that fall under these categories. Other assessments for the ability to open up an airway or central airway is a previous CT scan, which is very important. Previous bronchoscopy, as I mentioned, a quantitative perfusion scan to see how much lung function there is in the target lobe that you're trying to open up, and direct visualization. So we put airway contrast in parentheses. This is something that we do in our facility, and that's something that I can also touch base on throughout this talk. So this is the actual patient that we mentioned. On the left, you can see that when we inject airway contrast, you're not really seeing distal airways throughout. And then when you look at the right video, you can see distal airways throughout. So when you look at this patient, we knew on the CT there was a left upper lobe mass, and it was so infiltrative that there's nothing really patent in that left upper lobe. Or the way we teach the fellows is, if you're really looking for lobar patency, if the contrast doesn't go distal, it may not be favorable to open this up or place a stent. But when you look at the left lower lobe, you can see distal airways. So how is this important? So if you have left main obstruction, it may be worth opening that up, just because you can open up the left lower lobe and maintain that for this patient, especially someone that's in respiratory failure. Okay, so goals and expectations. Do airway stenting benefits last? Yes, they do. With these studies, you can see at 60 days, they maintain patency after either a silicone stent or metal stent that's placed for central airway obstruction. And these are patients with malignant obstruction. One of the caveats is that you've relieved the stenosis in the initial implant. So if you have a patient with 80% blockage and you were able to deploy a stent and have more than 50% patency, these are the patients that will maintain their patency over at 2 months. Do patients feel better after stent placement? So whether it's for malignant or non-malignant disease, this is a mechanical issue. So if you're able to open up over 50% of the obstruction, patients will feel better. So their dyspnea scores and breathlessness scores do improve. And what we see with transplant patients, pulmonary function tests, they do improve. And you know, the reason I kind of highlight transplant patients is because they get clinic appointments right before these bronchoscopies, they get PFTs, so we can readily see this trend. Because you're relieving an obstruction and possible atelectasis, you're improving your forced expiratory volume, even your vital capacity. And because there's less narrowing, peak flows are increased, and then there's better gas exchange, so the PO2 is increased. Sometimes you don't see these if patients, you know, for example, with malignant central airway obstruction, typically these are patients with chronic lung disease, so you may not see a dramatic benefit, but there is benefit on the dyspnea scores, and that's the things that we see clinically, is that even though PFTs don't improve in these patients, they do feel less short of breath. So goals and expectations, quality of life. Most patients that we intervene on, whether it's a transplant patient or a cancer patient, they do, and if they get benefit from this procedure, they are happy that they underwent the procedure. So this is a study where 81% of patients that had a stent placed for central airway obstruction had immediate improvement in the dyspnea scores, which is a good sign because you want to get a patient that is symptomatic, and if it's all related to the central airway, relieving that obstruction will give them benefit. Usually greater than 50% of persistent symptom score improves and even persists at 8 months. 100% of patients and 60% of caregivers regarded the stent placement as worthwhile, and despite an average survival of 11 weeks post-stent. You know, a lot of these patients, there could be a survival benefit, and the ones that do survive are usually typically the ones with the worst ECOG scores. Especially a patient like this that's on the ventilator would benefit much more dramatically than someone that's not on a ventilator. Informed consent. So this is one of the key aspects of the procedure, in my opinion. Discussing the outcomes, expectations with patient and family members. You know, we do quote the acquired data where there's 93% success if we're able to place a stent in terms of opening up the obstruction, with a 4% complication rate and mortality of procedure less than 1%. And typically those mortality is from airway dissection or just bleeding. Complications and mortality will be additive given the patient's clinical status. So the things with the highest red flags when you take a patient like this for debulking or stent placement is renal failure, active infection, left main disease, and nutritional status. So these have always had a lower success rate and more complications. In my experience, renal failure, active infection, nutritional status, these are the common things that we see where patients are just failure to thrive and not a good surgical candidate to undergo a procedure like this. And you know, typically when we have a patient in the ICU, if they're on pressors or you know they're clinically deteriorating, you know, these are obviously the patients that are not going to be subject to a procedure like this. So what you want to do if you do get a patient and you think an intervention is warranted, the pre-procedure aspect checklist is important to go through, especially because not all facilities are the same. So the operator, you need to be comfortable with whatever type of ventilation you're gonna do during this procedure. We do jet ventilation. You know, if you use a conventional ventilator with a rigid bronchoscopy, you know, you can pack the mouth and cause, you know, a partially closed system, which may work. Or, you know, if you're a place that just uses flexible bronchoscopy and an endotracheal tube, you should be comfortable with stent placement and removal. You know, I think for the most part, stent placement, you know, if you look at the IFUs, the informational for use, when you're getting these stents, they come in the box. They tell you how to place the stents, but removal could be tricky. So that's one area that needs to be taught. Anesthesiologists, they need to be comfortable with jet ventilation, rigid bronchoscopy. If there's complications like bleeding, do they have endobronchial blockers? And if it's a patient that is somewhat in the gray zone for stability, getting a central arterial access before you do the procedure may also be warranted. OR staff, you need to have people that are experienced with airway procedures, especially procedures that you do. When I get an airway case like what we just presented, I wouldn't want to do it with the lay team after 5 o'clock at night. This is a thing that you want to do in the daytime if you think there's any potential complications that may happen. And if it's a patient that's not doing well, or you think you need additional support, calling the ECMO team or a thoracic surgeon prior to doing a high-risk procedure like this is also warranted as well. So we've had patients where we had to place on ECMO just to do a central airway obstruction intervention, especially if it's a young patient. And we've had thoracic surgery on board as well, just in case it's I can remember a case where we were removing a stent that was placed in an outside facility that was left in there for close to 18 months, and it was really difficult to remove. So having a lot of people on board to help is a benefit. This is an area that I think is constantly in flux and changing, probably in a good way in our fields. There's these commonly used stents for silicone. What we typically use is the Novatech stents. There's this designation of metallic and hybrid stents. I like to designate them as partially covered or fully covered because there's still metallic stents. We preferentially place fully covered nitinol stents and Merit stents and ICAS stents. ICAS is a little bit different than the other stents because it's a balloon expandable stent, and that's something we can talk about in a little bit. And there's also bioabsorbable stents coming out that's made out of amnion, and that's also getting a lot of press these days. So the question is to stent or not to stent. So your options during a procedure, and this is something I try to tell the fellows, your main goal and the reason why you bring this patient to the procedure room is to do something. But just because you have a mindset of doing something doesn't mean you need to do it. So if you look at it and you're in there and you say, there's really nothing that we can do, you can do nothing. I think people are tempted to try to do something even if you're there. But you can decide on doing nothing, and it's just and that's fine as well. If there's really nothing you can do and there's nothing you can open up, for example, if there's a left main obstruction and you can get around the mass, but there's really nothing distally that you can find, then it's not beneficial to open up the left main stem. If things are getting hairy and it's not going the way you want, or you don't have the people that you need, the equipment that you need, you can always abort. I tell fellows this all the time. You can abort and revisit the procedure if you think the procedure is still warranted. Bring another colleague with you, or have your main anesthesiologist or surgical tech with you. So it's not. These are not things to be shy about. There's times where I wish I would have aborted cases. So these are kind of learning things that you see throughout your experience when you see patients with central airway obstruction. Okay, so the things that we can do, so dilation with a balloon, this is probably the most common thing that any one of us are going to do when we see patients with central airway obstruction is, can we just dilate it? So we expand, so the balloons, the mechanism is to expand tissue by radial force. And in doing so, you provide a little bit of tearing. You need a conduit, so you need a distal end. You need a landing zone. You wouldn't want to dilate anything that you can't see past beyond, and you're not sure what you're dilating to. The advantages is that it's easy, it's flexible, it's consistent. Anyone can do it. If you're writing good procedural notes, they'll just copy what you did. So it's very reproducible. The new balloons, you can visualize what you're doing through the balloon, which is nice. And it's also good for hemostasis. So these will work with focal stenosis, granulation, or tumor, and with mixed central airway obstruction. If you have any malacia, it's not going to be the best because it's just weakness of the airway caliber. So there's really not much to dilate. So worse than, that's probably not the right term, but I would say it's probably less efficient in a molastic component, like I mentioned. And if you have diffuse stenosis, extrinsic disease, those also will be difficult to dilate. These two that I mentioned, typically, if the patients do feel better, it's for a brief moment, and there may be a time where you're going to have to consider placing a stent on those type of patients. Tissue debulking. So this is another thing that kind of goes hand in hand with intervening on central airway obstruction, because you're going to see some type of endobronchial disease if they're that severe, and if it's from a malignant etiology. So the main point is to restore airway patency. You want to understand the airway anatomy, because a lot of times the mass and a lot of the mucosal involvement will make the anatomy very abnormal looking. So it's when you see cavities and holes, you don't assume that that's an airway. So there's things that you need to do to try to assess if those are just areas, those are just fistulous areas, or areas of malignant tissue. So you do need to kind of figure out if this is a real airway or not. And we typically use airway contrast, like you saw the pictures before. That helps us a lot in determining those differences. And then the other reason to debulk is to have, if you're going to place a stent, is to make the stents fit better. So there's times where the stents may not conform to a certain anatomy where there's a mass within the airway. So you may have to debulk a little bit just to get the stents to fit. So how much do you need to debulk? So, I tell my fellows that, there's no exact number. It's really enough to make a decision. So if you debulk enough and you're able to get past it and see distal airways, to me, that's great. I usually don't spend another 30, 40 minutes trying to debulk the tumor if I can just put a stent across it. And if you don't see anything past it, then those are the things where placing a stent might be really risky, and we try to avoid those. So there's different techniques for tissue debulking. What I typically do is mechanical debulking. I think it's faster and cleaner. We use rigid bronchoscopy, scissors, graspers, a microdebrider. I can show you the video about with this particular case at the end, where suction really helps us as well. Thermal energy, you can use laser, argon plasma, coagulation, radiofrequency ablation, electrocautery, and even cryoprobe and cryotherapy. There's delayed techniques like photodynamic therapy, which we don't do too often. Stent placement, the indications to immediately restore airway patency. It's for malignant disease, so benign disease is off-label but still done. How do I pick the right stent? So there's different types of stents, like I said, silicone stents and hybrid stents. You want to know the diameter and length of the stent that you need for the particular application, and that will also kind of affect what type of stent you use. When you select stents, when I started, it was very easy. So we had one type of silicone stent, and we had one type of fully covered hybrid stent. And that was about 9 years ago. And now there's multiple different types, and I think that's fine. And it really depends on your preference and your experience. If you're really good at placing one particular type of stent, just keep on doing it. It depends on availability, what you have in stock. The ability to deploy the stent. There's certain stents, obviously silicone stents, it's going to be very hard to place through an endotracheal tube. So rigid bronchoscopy is necessary, in my opinion, for placing silicone stents, especially if you're trying to remove them. So if you're not a place that performs a lot of rigid bronchoscopy, you may be looking towards the hybrid metallic stents. And then, yeah, so ability to get into desired airway, so that's always important, right? Location by length and diameter. Trachea, we typically use the Merit Bonastent and silicone stents. For bronchial, Merit Bonastent and silicone, and also ICAST. They have a 10 millimeter ICAST stent, which is the biggest one in diameter, and you could actually over dilate that to try to fit the airway. The reason I put left main in the Bonastent and silicone is because the Bonastents actually have a 60 millimeter length and a 50 millimeter length, and those are really good for left main because they're a little bit longer. Merit doesn't have 50 millimeter length; it just goes 40 and 60, regardless of the diameter. So so that's something that you might think about when you're choosing the type of stent. For lobar obstruction, we typically like the ICAST stent. There's also Merit and Bonus stents. They make them smaller. We like the ICAST stents because you can get the flexible scope to flex into the lobe that you want, and they deploy relatively easily. Stent diameter and length. So there are some tools to figure this out when you're doing your bronchoscopy. So there's something called the Aerosizer. This is made by Merit. I've never used this per se outside of just preclinical testing. So what you do is you pull the grasper, and then you see those two flanges pop out. And based on the color of the length of that flange, there's a color to it, and that's coded to a certain diameter. We don't use that typically. Airway balloons, typically if you dilate to a certain diameter, and if it's not loose and it's catching on the airway, we typically add 2 millimeters to that for the stent size. But what we typically teach is operator experience. So for me, the trachea, I usually go with a 16 to 18 millimeter diameter stent, depending if having a CT is also important. So sometimes you'll get a trachea that's over 20 millimeter. But for the most part, 16 to 18 has been okay from our applications. The left to right main stem 10 to 16 millimeter. Typically I go 12. I like the 12 and 14 millimeter diameters. The lobar bronchus 6 to 8 millimeter. They're a little bit smaller, obviously. Determining length is also important. So what we typically do is you can look at the CT chest and get a general measurement of length and diameter. Using the scope, we have a ruler during the case, and we get the tip of the scope to where we want the distal end of the stent to be, and we pull back and we measure that length where we go from distal to proximal. So we do that 2 to 3 times and make sure we get a good measurement, because that's going to be the most important thing, especially when you're going through all this trouble to get the patient assessed, get the patient in the procedure room, do your debulking, and the last thing you want to do is place a short stent or too long of a stent where it doesn't fit and you have to replace the stent, because that typically adds another 20-30 minutes to your case. So there's a couple ways to do stent deployment. There's the fluoroscopic method. So you determine the distal portion of where you want the stent to be in the airway. You place a marker on the chest. We typically use a peripheral needle and just tape it on the chest, and some people use paper clips, whatever you want to use. You advance the wire, the stylet, all the way down past to where you want to place the stent, and then leaving that wire in place, you pull the scope out, and you may want to use fluoro to kind of check to where the stylet is not being pulled out too much, and then you advance the stent through the wire into the exact location and deploy the stent slowly. So all these stents deploy distal to proximal. So you'll see the distal side opening first, and then you can kind of make micro adjustments in the beginning when you're first starting to deploy, and then there's going to be a point where you fully commit, and then you deploy the stent. And obviously, you go back in with the scope to visually check. There's a direct visualization method, which we typically do, and I think, you know, once you're more experienced with placing these stents, this is something you may be comfortable doing. This is a Merit Aero stent. They have a green marker to them, and you know, someone can correct me if I'm wrong, but I think they're the only ones that have that marker. What typically all of these stents are housed within the sheath, and the stent doesn't move, but the sheath retracts back and deploys the stent distally. So that is the mechanism. So when we tell fellows that are you know learning this, we never say push, so we always pull. I can show you the example here. So when you line up the green marker, that proximal line is kind of where we want it to land. So we want the proximal end of the stent to land. So you kind of make micro adjustments within the airway, and you want to see that green marker right at that point, and you make these little fine-tune adjustments. And because there's no, you know, we're not deploying a stent in an airway in this video, it's just on a piece of paper. When you're deploying the stent distally, you know, that it catches to the airway, so there's not that much movement as you see in this video, but that's the typical concept when you're placing these stents under direct visualization. Stent complications. So as we all know, you can get perforation of the bronchial wall, especially if you're placing stents that's not a true airway, especially in patients with really difficult anatomy, and due to whether it's a transplant patient or cancer patient. Stent migration, you know, this is one of the reasons where, you know, you place a stent and you're glad you have partners and they can come in and help you out if you're not on call. But you know, typically, you know, in our experience, most of our stent migration comes when we place a stent in a malignant airway, and they're undergoing treatment, and then the stent becomes smaller than, you know, what you intended it to be, because now the airway or the tumor, you know, those things have been resolved, and the airway caliber is bigger. So that's something that you don't really, you do expect it, but you tell patients that the stent may move because you're getting treatment, especially if they respond. So stent migration, for us, that's the typical scenario. And the way we get around it is that we do have surveillance bronchoscopies for that patient. So we never forget about the patient. So we can always see when it gets loose, and then we remove it. So we've really kind of toned down on, you know, these unexpected, you know, ER visits where the stents are now in the trachea, things like that. Retention of secretions, again, we do surveillance bronchoscopy. We also send patients with normal saline nebulizers in addition to a flutter device to help them cough. So for us, though, that is our stent hygiene regimen. But we still see patients that retain secretions and come in a little bit more short of breath, and more often than not, there's more mucus obstructing the stent, and we clean it out. Excessive granulation tissue, you know, we do see this. That's what we do during these surveillance bronchoscopies. We see this, and typically our experience is, you know, we place a hybrid stent first just because they're readily available. And if there's patients that really react to that from a granulation tissue standpoint, we then choose softer materials like silicone. And then if that's not enough, we go to custom stenting, custom airway stenting. And then tumor ingrowth, that's typically, you know, for stents that are not fully covered. And because we're an institution that use fully covered stents, we don't see that often. Post-stent management. So there's a conservative versus a surveillance approach. We take more of a surveillance approach. Once we place a stent, we repeat the bronchoscopy in 4 to 6 weeks. And then for every surveillance, it kind of gives us data points to determine, you know, how often we should be doing the bronchoscopies. The stents, they inhibit the mucociliary escalator, so we give them a stent hygiene regimen, which is a nebulizer and a flutter device. If they fail this, we've done hypertonic saline, mucomist, Dornase, guafenicin, and antibiotics at extreme cases. Extreme cases, we give them a vest as well. Team patient coordination, I tell my fellows, they want to place stents, but in real life, there's an indirect relationship between placing one and your quality of life. So be very diligent when you're placing these stents, and make sure you're placing stents in patients that need them. Dedicated RN team and a on-call messaging system is very important, because these stent patients are basically round-the-clock care, especially if they're having problems with it. You need to take care of it. Patient education and support groups are also important as well. Stent removal. So for the most part, these stents are indicated for permanent use. So not all of them by FDA need a removable mechanism. The little loops that you see on the Ultraflex and the Aero are typically for repositioning, but they also teach you how to use that for removal. We use non-traumatic forceps just because those sutures could be pretty, if you're grabbing really hard, you could cut the sutures. We use rigid bronchoscopy for all of our stent checks and stent placement. So when you have rigid tools, taking these stents out are a little bit easier than using that suture method. So we when we have a stent that needs to be removed, so we always plan for the worst. So we have we like using the rigid bronchoscope, as we said, versus endotracheal tube. So we always place that. And sometimes you're going to be, if these are the cases that you're going to do, you're going to remove stents that you haven't placed, just like that example I said from an outside hospital. And those tend to be things that are, you may need some backup support for, especially when they've been out for over a year or so without a check. And then make sure if you have a patient that you feel needs additional support, like ECMO or surgical support, make sure you also have that lined up as well. So final thoughts. Just in my opinion, I think airway stenting is here to stay, but there's no ideal stent. I think, there's technology, epidemiology of airway disease is transforming this area, and hopefully that there are better stents that are better tolerated for our patients. You consider patient factors prior to placing a stent, so the expectations, reliability, managing complications. Reliability is huge. You don't want a patient, you don't want to place a stent in a patient that's going to disappear. You want to make sure there's a system that there's going to be some follow-up and reliability, because that's very important. You want to consider operative factors, the efficiency of your system, your team, the tools that you have, and how comfortable you are in the removability of these stents. During cases, or even when you're getting a consult, it's okay to say no to these cases, especially if you don't think the patient needs it or you think it's high risk. And even with experience, having support is crucial. We're pretty lucky to have good support, whether it's for circulatory support, ICU support, or surgical support. All of those are very necessary when you have a challenging patient. So for this patient, I want to show you the video of what we did. I don't know if you remember, but it's a left upper lobe mass causing left main stem obstruction. We saw from the airway contrast images that the left upper lobe, there weren't distant patent airways, but there were patent airways in the lower lobe. So we decided to do the left main stem debulking. So we use a mix of modalities. So you just saw a rigid suction tube, and you saw how efficient that was in removing tumor. So this is I'm going to pause this here. So this is a aero stent placed in the mid to distal left main. At 11 o'clock is that left upper lobe. So that had no distal patency even when you put airway contrast through there, but the left lower lobe did. So this was one of the main reasons why we decided to keep this airway open. In addition to, obviously the patient is in respiratory failure. Let me fast forward that. Let's see here. Okay. And then the patient did well after that debulking and stenting procedure. You can see before the intervention, which is on the ventilator, obviously, and then on the right, there's a left main aero stent. You can see the left lower lobe opened up pretty nicely, the big mass in the lingula left upper lobe. And the patient was extubated and underwent treatment for advanced stage lung cancer. Okay, so that's it for my talk.
Thank you, Dr. Cho. That was a fabulous presentation and super informative. I'm going to welcome back Dr. Hussam Nayef, and maybe we can get some questions started. As a reminder to the audience, feel free to submit them by using the chat or question feature. It's on your control panel. You also may request to raise your hand, and then we can give you microphone access. Dr. Nayef, I'll let you take it away.
Excellent presentation. I think covered a lot in a very short term. I have some questions on my own. There's some questions from the audience.
Sure.
I think the one thing and this is something that comes up a lot, and what drives your decision when you're approaching a possible central airway obstruction to start off with a rigid right from the get-go, or maybe do an LMA and inspect in the OR and transition into rigid? What makes what factors do you take in making that decision?
Yeah, that's a good question. So if we have the luxury of an intubated patient, we can do a bronchoscopy and really get the lay of the land. So that's why it's very important when a patient is being transferred to you, if they've had a bronchoscopy at that outside facility, it's very important to get those pictures, because the more data you have, the better informed you're going to be for these procedures. So rigid bronchoscopy, for example, if we have a patient that is very hypoxic on the ventilator with an endotracheal tube, we're not going to extubate them and put a rigid bronchoscopy, rigid scope, right? So we're going to try to do our best to do it through the endotracheal tube. So we always try to, do the best we can. But there's sometimes patients where the tube can't be sized up. So the biggest tube that they can put in is a 7.0 or 7.5, and for us we need room, right?
Doesn't fit, yeah.
So if they need the intervention for whatever reason, then we'll call for ECMO support, things like that. There's been times where we've placed the ICAS stents, because those are really, in my opinion, it's really nice to have in your back pocket, because they can fit through a through a therapeutic scope, a 2.8 millimeter. And you can always balloon dilate that up. So
it's challenging though to place them. It's not easy.
The ICAS stents?
The ICAS, yeah, they're very tricky. They are.
Yeah, it's funny, the getting a that company, it's their first indication is for tracheobronchial disease, but mostly it's a vascular stent. So they really hold a lot of training to place those kind of stents. So if you're someone who wants to try, it's not like you can find an event and that'll teach you how to place them in the airway, right? So if you have them in your institution, I would recommend getting the rep and maybe practicing out like in an artificial airway, and just just to kind of get a feel for it, if that's something that you're going to be doing. So I can't really say more about those.
No, thank you. I appreciate it. The second question I had, and it's kind of a two-part question. You mentioned something, and I think I wanted to underscore that you really don't want to dilate what you don't see distally, right? So the first question is, what do you do? Is that when you use the airway contrast to know if there's more patent airway distally? And the second part of the question is, I remember from my mentors and that there is a time frame for salvageable airway obstruction. Is that
Yeah.
something you also implement? Do you use, and what's your practice been?
Yeah. So over the, you learn those kind of no-go criteria, right? So if the lung is abscessed and necrotic, that means it's more than the acute phase. And typically, even if you opened it up, you wouldn't get any functional gas exchange or anything like that, right? So it's not an efficient way of spending your time. And then this 4 week, if you have atelectasis in 4 weeks or more than 4 weeks, there's less chance of it being able to be recanalized. So, I would say that if you have a lung that's necrotic or you have a huge solid lung mass, yeah, those you're not going to be able to open up. But the thing is, you're not sure if it's if you can open up the lower lobes or maybe the upper lobes. We've seen patients with for example really narrow airways and it's just mucus in there that's causing the obstruction, and you suction that out and they open they open up. So the time frame is I think it's a general rule, but I don't think you really know unless you take a look. And for us, we don't open anything that we can't determine distally. So for us, a lot of times your gross direct bronchoscopy inspection, there's just so many things happening distally, especially in malignant airways, that you can't really tell. So that's why when we know we passed the initial obstruction, we inject contrast, and if we see distal patency, then we try to open up the the main stem bronchus, especially if they're in respiratory failure. So that is the main. So we use contrast a lot in those situations, especially if there's a if there's something that looks like an airway and we don't the anatomy is very difficult, and we so there's been a case where we thought it was an airway, we injected contrast, and contrast went down the mediastinum, so it was a bronchomediastinal fistula. So obviously you don't want to dilate that or place a stent for that. I haven't found any other good way of assessing that, and I don't know in the audience if they have other means of doing it, but to me, that's kind of our go-to diagnostic tool.
Okay, awesome. So we have a couple questions from the audience. What factors do you take in when you're dealing with central airway obstruction debulking plan in the modality of ablation, cryo, ice versus fire, I guess?
Yeah, right. I'm a little bit more simplistic. So my goal is what's going to get me in and out as fast as I can.
Laser.
Typically mechanical debulking is pretty good, especially if you have rigid scope. If you see that video, the suction, just the rigid suction catheter was removing a lot of that tumor. So whatever is quick. The cryo probe is very, it's a small area. You'll be there forever trying to debulk a tumor, and maybe that's the only thing you have. So for me, it's we favor the mechanical modality because I think it's faster. There was a time where we didn't use rigid bronchoscopy. It was just all under flexible scope, and we've used the cryo probe and APC and all of those things just because we didn't have
the set.
But once we had rigid bronchoscopy, you can appreciate that the mechanical debulking part of it is it's very favorable.
And you get the tamponade after you core out or do whatever you need to achieve hemostasis. Excellent. So another question: where do you use the new metal Y stent? I'm guessing the ICAST similar.
The new metal Y bonus stent. Yeah, so that's actually one that has kind of impressed me a little bit. So typically when you have before, so they've had metal Y stents, it just wasn't FDA approved, right? So it was in different countries. So we were kind of just, you know, reliant on the silicone wise, right? So they're a little bit difficult to place. You know, I mean, you know, you need a rigid bronchoscopy, a rigid bronchoscope. You know, some people, you know, there's ways you can do it, but you know, an unstable patient, you know, for us at least, you know, we're a little bit more. We'd rather have a secure airway. So when the carina isn't sharp, right? So when you have a really broad main carina, the Y stent usually doesn't fit very well. The silicone Y, okay, they don't fit that well. So what we've done in the past in those patients is placed 3 metallic stents, right? So you know, if we needed a Y stent, but you know, recently we've used the Bond stent, you know, the metal Y stents, and they're pretty good. They actually, when you look at some of the videos, I have one on the Interventional Pulmonary our YouTube channel, but you have a broad main carina, and then when you place that metal Y stent, it actually, you know, that carina conforms to the stent, so the airway actually turns into a sharp main carina. So I'm really impressed with the way that it can take that kind of broad main carina you know, issue. So we do like it for that. And you know, I know my partners, you know, they'd rather place metallic stents than silicone Y stents, so it's a little bit easier to place. So I think if you have you know, any kind of main carina issue with this obstruction in essentially, you know, the proximal main stem bronchi and the distal trachea, that's a really good thing to use. They have different sizes, and typically we haven't had any trouble with the different sizes that they offer. So you have to make some good measurements. You know, I had one of my partners placed it for esophageal fistula in the left main, so they just chose a more distal limb on the left side. So yeah, that's just actually we've been using it more often, just, you know, because I think just the comfortability with the placement has been pretty good. So
Okay, excellent. I have the last question for today, and you talked about stent complications. So post-stent granulation tissue, how do you deal with that?
yeah, so you know, for us, we typically see it in non-malignant disease more often than not. You know, for the non-malignant central airway obstruction, the population that we do it the most is lung transplant patients. So I can speak to that. Typically what we do is we place the metallic stent first just because of the availability, right? So, and then we do a surveillance, you know, check after the initial placement in 4 to 6 weeks. So if we're seeing a lot of granulation tissue formation, for the first thing I do is actually I take a biopsy of the granulation tissue, send it for path and culture, because a lot of times what you'll see is, you know, they might have a ongoing infection, and just treating the infection. Any infection will accelerate granulation tissue growth. So you want to get those kind of basics out of the way. And then we try to change the metallic stent into something a little bit, you know, a softer material like silicone. So we'll place a silicone stent. And there's ways to make the silicone stent a little bit more softer and more forgiving with the airway anatomy. And if that becomes an issue, then we've put in the custom 3D stent, you know, the Visionaire. So those are the kind of steps that we take.
Okay, excellent. Well, thank you so much. I think we're towards the end of our webinar for tonight. So thank you so much for this awesome webinar, Dr. Roy Cho. And good evening, everybody. And we enjoyed this webinar. We'll see you next month.
All right, thank you.